say thank you for tuning in to just say quite a niche topic that we'll be discussing today, but one that certainly air forces around the world have been quite exercised by over the last, well, 80 plus years really, and still haven't got a perfect solution for. Quick background I've been asked to give on myself. So I am an occupational medicine specialty registrar. Very fortunate to be in the full specialty training programme supported by the military, ST4 at the moment, finishing a couple of years where I've been working in an occupational medicine department at Bryce Norton. So in terms of what we do here, effectively we're providing specialist top cover for predominantly GP provided occupational health delivery that exists within primary care across the military. So quite an unusual setup there, but it gives us the opportunity, certainly as trainees, to dip in and out of a very wide variety of places. We cover, I was in Scotland a couple of weeks ago because we cover with bases up in the north there, as well as, you know, around the whole country, and seeing a range of hazards, both on the aviation side, but also more sort of heading into industrial hazards, plus the more normal day-to-day occupational health stuff of, you know, stress and mental health. So very fortunate. I've had quite a broad base of first couple of years of training. Almost my last day on the job, I'm due to then head off to medical boards where we deal with more sort of ill health retirement type work, which is another side of our piece. So hopefully that gives a little bit of context there. My original background is in general practice, and I've also spent a few years doing full-time training for pilots and doctors in aerospace medicine along the way as well. Right, and really it's out of that experience, including setting up centrifuge training, a new model of centrifuge training, that, you know, my interest in the effect of G-forces as an occupational hazard, you know, that's where that came from, and led me to putting together this research project that has I've been doing part-time alongside my clinical work as part of the faculty's curriculum requirements. So here we are. I've been doing this in collaboration with King's College London, but a different bit of KCL to possibly the usual bit. There's a small centre that deals with aerospace medicine specifically, that sits within the physiology, human physiology department, and Dr. Ross Pollock has been my supervisor for this. I think that's enough introduction, so we'll crack on. So, talking about the issue here, as I say, most people won't be particularly familiar with this, but essentially, as soon as we've put people into relatively high performance aircraft, and certainly aircraft that are capable of very rapid manoeuvres in the air, there's been an empirical observation that at times people essentially lost consciousness, fainted in the air. And particularly when you're the only person in an aircraft where that happens and you're going at some speed, that obviously has potentially catastrophic consequences. So this is, you know, quickly identified as a risk to life in that sort of high performance aerospace environment. It really doesn't affect civilian aviation as far as passenger transport goes, because the aircraft involved just don't do these sort of manoeuvres, but anything involving sort of aerobatics, air racing, potentially on the civilian side, there's some crossover, and again on the military side, any military pilot training, this is a core part of military pilot training, is exposure to these kind of fast manoeuvres, and it's also core to air combat. Essentially what you would do in a jet aircraft to try and shoot the other person in the back before they shoot you down. So that's fundamental to military aviation, somewhat peripheral to civil aviation. And essentially we've characterised this phenomenon. I'll discuss the physiology in a bit more detail, but it leads to around half a minute of incapacitation. So part of that is absolute incapacitation, where, you know, you're usually just slumped down, completely unconscious, as you'd expect from seeing anyone who's fainted. And then there's a period of roughly as long again, where essentially you're regaining consciousness, but you still don't really understand what's happening, and you're certainly not able to control an aircraft. And, you know, you could be travelling multiple miles at fast jet speeds in that period of time. So clearly the implications, especially if you're solo in the cockpit, are obvious. We've known about this for a long time. We've known also that whilst we have formal safety reporting systems within the military, we do get some reports of this, but we don't get lots. And So the pragmatic response to that within the aerospace medicine community has been to conduct periodic anonymous surveys. We've got now a range of those, and this is the latest one of those, to try and understand this, how this problem affects people in more depth. So essentially, this is a very basic form of epidemiology that I think I've been doing here. Just to go through that physiology in a little bit more detail. So essentially, for an aircraft to turn around, to change its direction, it can't turn like a car from side to side. Instead, effectively, all of its manoeuvres are in pitch, so either pitching up or pitching down. And the only question is whether the aircraft sort of rolled its wings beforehand, in which case that manoeuvre will be in a horizontal direction, or if they just pitch straight up, in which case they're moving in a vertical direction. Because the pilot inside cockpit is moving along with the aircraft, that means the force that they experience as a result of that pitch is essentially usually experienced down through their body, effectively increasing their weight. And in a civilian aircraft, an air transport aircraft, you might get 20-30% increase in weight if they're sort of pushing the plane around quite a lot. But in a military fighter aircraft, that could go up to 9 times your normal weight, which clearly has some potentially significant physiological effects. Those effects can be quickly summarised into two main issues. Both of them add up to the same problem, which is that your cerebral perfusion pressure, so the amount of essentially blood flow that's going to your brain, can reach 0 quite easily. And that comes from essentially, say, 2 linked problems. Number one of which is the blood volume ending up in your legs, rather than distributed more evenly through the body. And the second issue is just that the weight of the blood column that sits between your heart level and your head level increases in proportion with that additional gravitational force effectively you're under. So, that weight, that blood column could be up to 9 times what it was previously. And those 2 issues essentially come together. They're both synergistic. They both make the problem worse. And if your body can't react in time, the risk of that is that you lose consciousness after around, a minimum of 4 seconds, because that's roughly the period of time the brain's still got that bit of ATP, physiological reserve, to keep itself going without any further oxygen supply. That's the physiology there. Questions on that? Very willing to chat about it, but for the sake of argument, we'll move on now, and we can always put that into the questions later. I mentioned that we've got some previous data on this, surveys essentially went back to 1987 with relatively similar findings over time. So this is essentially a view of how many air crew across the Air Force, cross-sectional at any one time, have experienced a loss of consciousness related to G that they're willing to report anonymously. Those were relatively stable at around 1 in 5 for our first 2 surveys. The third survey, conducted just over a decade ago, took a slightly different approach, looking at both full loss of consciousness, but also a more recently recognised phenomenon where you have a sort of a partial loss of consciousness, which is described as ALOC. If you looked at just the people reporting the full loss of consciousness, the prevalence had gone down a bit. If you add in this newly recognised phenomenon, the overall prevalence was higher. So we've been doing quite a few things in this time to try and increase awareness, increase training, reduce and to try and reduce the risk with that. But relatively stubborn levels of reporting continued. In the last 10 years, so we haven't just been sitting on our laurels. What do we try and do about this? So one of the big things is improving essentially PPE. So some quite specific personal protective equipment that's worn for G. So if we remember that blood pooling in the legs is a significant contributory factor to this, you can overcome some of that effect by essentially putting people in a pressure jacket and increasing the pressure around their legs and lower abdomen, which the aircraft can do essentially automatically in time with the onset of those gravitational forces. So that helps to counteract that effect. That equipment has been improved and that's been rolled out to more platforms over this time. In addition, you can also deliver really high pressures of air. And again, our respiratory specialists will be perhaps surprised to hear that we'd be delivering 35, 40, 45 centimetres of water, pressure automatically via a tight-fitting mask to pilots in flight, and that essentially increases the intrathoracic pressure, squashing the heart, simple terms, but increasing the heart's ability to overcome the hydrostatic gradient from heart to head level during that time. So pressure garments plus that pressure breathing for G, which actually feels surprisingly natural when you're under that level of G. So those are those two there. So rolling those out to more platforms. Essentially, the way that we get pilots to avoid passing out in this situation isn't just the PPE, though. The other big control is administrative control, which is just training them, because a very unnatural set of manoeuvres, both really tensing the lower part of the body, plus doing a very unnatural breath straining manoeuvre, which increases the intrathoracic pressure further. Those two combinations can essentially support your blood pressure despite these very high levels of G quite comfortably for the 8 to 12 seconds until your natural baroreceptor responses are kicking in and helping to manage the problem more physiologically. Very unnatural manoeuvre that we're teaching people. They don't take long to learn it, but you can't do it on the ground without passing out. So essentially we end up buying a very replacing our previous 1950 centrifuge with this rather fancy modern man-carrying centrifuge, which essentially delivers similar force environment to the aircraft, but going around in tight circles at 60 miles an hour rather than much bigger circles at 400 plus. So that gives us a sort of a relatively controlled environment to provide that training, and we've improved the way we do that. It uses flight simulation now, so it's hopefully more realistic, and we've got quite positive feedback for that. So that is G physiology and training, hopefully done in 10 minutes or so. Right, so on to the actual research. So reassessing the prevalence of G-induced alterations of consciousness. Again, one point to critique here. We did change our definition slightly in the sense that certainly our RAF lead was quite concerned retrospectively that people would struggle to self-report the difference between fully losing consciousness and partially losing consciousness, because ultimately in both situations you're losing consciousness, you don't really know what's happening. So that was felt internally to have maybe been a methodological error in the past, and so we tried to group these together into one lump essentially to make that more robust. And our hypothesis was that there'd been overall reduction in prevalence since the 2012 survey, although noticing no subtle issue with the definitions there. And in addition to that, we wanted to help to just understand pilots' attitudes towards the risks and also the mitigations that have been put in place. As I've suggested from earlier, we conducted that using an anonymous cross-sectional survey. Fortunate to have access to Red Cat platform via the Royal Centre of Defence Medicine, which took all of that data handling off our hands, and we also broadened out the eligibility criteria compared to previous surveys, which have just been focused on the RAF. Ultimately, pilots in the military could be under either the in an Air Force uniform, in an Army uniform, or in a Navy uniform. Increasingly, we've got civilian pilots flying in military aircraft under military regulations in some situations as well. They do subtly different jobs, but they're not that different, and the training is quite common as well. So we felt that just restricting this to the RAF wasn't appropriate, so we broadened those out too. The plan was to use a simple 2-sample Z test to assess the main hypothesis on that change in prevalence. Responses. So we had a reasonable response, but not, not as good as we'd had historically, but not what it is. It's enough to work with probably. So 403 responses of a total from a total pilot population of around 3,600. Discuss that in a bit more detail later on. There are reasons for that. Median age 37 years. So these aren't all bright new young recruits. And 21.6% were reporting at least one incident over the course of G-related alteration of consciousness over the course of their careers. So a similar number to the loss of consciousness reported previously, but lower than the total figure from 2012. If we just pin that down to the RAF pilots to increase the comparability with the previous survey and with the sample size we had, that was clearly a statistically significant difference compared to 2012. So I think we've got some confidence that that our overall population prevalence has reduced in that time, though we can discuss critiquing that later. One other interesting thing that came out of this, which we haven't observed before, was that as highlighted in red here, a really substantial number of people were highlighting a lot of incidents across their career, and we just haven't observed this before, and it hasn't been observed previously in international studies. So this may be us widening out the definition. Previously, people report sort of 1, 2, maximum of 3, but no more than that. So an interesting subgroup here that we could probably do with looking at in more detail. And the other big obvious finding that came out of this is that historically, perhaps counterintuitively, we've seen a lot more of these loss of consciousness events reported in training aircraft rather than in frontline aircraft, even though the training aircraft are less powerful and less maneuverable. That seems counterintuitive, but because of the reduction in the levels of PPE, essentially the protective equipment that's in the training aircraft, and because of the relative inexperience of the pilots involved, perhaps it's made a bit more sense than you'd initially think with this. So that's been the historical picture. If we look at the total number of incidents reported, the Hawk T1, which is a fast jet training aircraft, comes out as the highest over time. But in a change from previously, if you look at more recent events, and pragmatically we've split the data from 2015 onwards just to reflect the last roughly decade. If you look at recent events, the largest single group is occurring now in our frontline fast jet aircraft, and that's a significant change from the previous from previous reporting, and may reflect a change in the risk pattern. Looking at when people lose consciousness related to the maximum level of G, again, you'd expect intuitively the more gravitational force, the more risk with this, and to some extent that's true, but this is significantly confounded again by the levels of experience and protection levels that people have. So actually in light aircraft, where there isn't really that level of G protection and people are less experienced, you're getting these incidents reported at much lower levels of total gravitational force. And 5G may sound like a lot, but it's pretty normal for experienced people to manage. You don't necessarily need PPE if you're really comfortable with the environment, but clearly if you're not, and a lot of these people aren't, then you can have some of these safety incidents. And again, interesting enough, in the fast jets where they've got more protective equipment, it's actually quite a wide spread of events across different G levels, rather than it's just all being right at the top. So common factors. So we asked people why they thought this had happened. Failure to carry out the anti-G straining manoeuvre, so essentially failure to carry out the training, was the top reason, and shortly afterwards limited recent exposure to high G and fatigue, and people could select multiple options for these, so they don't all add up to 100. And the recent exposure to the high G environment was rated as the most important risk factor for this, with people consistently rating that as extremely important on a Likert scale in the majority of cases. So bringing my discussion points out of this, as I say, with some caveats, I think the main hypothesis is supported. There are some definitional questions in that, but the reduction from 37.2 to 21.9 is a decent magnitude, and obviously statistically significant as well. So I'm reasonably comfortable with that. There's very few international reports that cover a broader range of alteration of consciousness events rather than just full loss of consciousness. Really, there's only 3, including the previous 2012 study, and ours sort of sits firmly in the middle of those, between sort of 14% at the lower end and 65% at the higher end, and we've got reasons that we think that's reasonable, but as I say, we're in the middle of the pack, and as I mentioned before, we've got these multiple reports from single individuals which haven't previously been described in any of the papers before. The if we try and split out the fleets into looking at frontline jets on one side and training aircraft on the other, on the whole, high G recency, so recent exposure to high G was the big thing that came out of the frontline jet instance, and we can discuss that a bit more in the questions if people are interested as to why that might be the case. On the training aircraft side, again, perhaps intuitively, failure to carry out an effective AGSM was the bigger factor in terms of why people felt these occurred. So we could sort of customize our advice to the different stakeholders sort of based on that rough division. In terms of limitations, I think I've tried to be open and to sort of discuss them as we went along, but we had a lower response rate than historical surveys. I think there's a few reasons I could highlight for that. One is that, you know, there's a lot of surveys out there these days. Military get a lot of surveys, and it is difficult to motivate people from that side. The second issue is a bit of a internal one, but the way that the RAF has done these surveys is they've thrown them out to all of the affected aircrew or pilots, and that means that people who fly helicopters, people who fly passenger jets, you know, if they're in uniform, they get the questions, and when that comes to their inbox, they go, well, this isn't related to me. Now, what they forget is that all of them historically have been through pilot training, military pilot training, and have been exposed to all of these risks, and because we're trying to get a valid cross-section of the population, we want to understand about their historical experience in flying training, because that's been a really big area of risk for us historically. But that conversation is difficult, and as I say, despite reminding and cajoling and so on that, I think it's a difficult one to overcome, and increasingly difficult over time. So response bias, I think, is a limitation that we're very aware of in these. So you would expect people who've had incidents to be keener to click the button and tell us about them. And so that could potentially affect data. Should hopefully be a consistent issue between surveys, so potentially wouldn't affect comparisons, but it's obviously difficult to substantiate that. And of course, recall error, because some of these events that people are recalling go back to prior to 1990. We've got some quite old and bold in the military, so there's always a chance that people have just forgotten what happened, and that could affect the quality of the data here. The other surprising one is that it's recognised that you can have complete amnesia of a loss of consciousness event in the air and simply be unaware that it's happened, other than possibly the aircraft isn't quite where you left it, or is in an unusual attitude. And this has absolutely been described, and it's been described in the centrifuge as well. So there is a real difficulty with self-reporting in this area. So to bring this into a conclusion, we would argue, based on this, that while there's some evidence the prevalence of these issues is reduced with all of our mitigations, that this positive G acceleration remains a relevant flight safety hazard in the military environment, and it remains a risk to life, and it's something that we need to keep attention and work on. We've got that sort of roughly 1 in 5 figure of UK military pilots experiencing at least one of these incidents over the course of their career. So we're continuing to use that in training to stress the importance of this. We've picked up that particular concern over recent exposure to high G in frontline pilots. There is a physiological basis for this, and we know that their exposure to G can vary a lot over time. So potentially risk assessing that and looking in and trying to work out in advance whether or not someone has had very little G exposure, and maybe working it up slowly could be a simple administrative control to help reduce the risk in their space. Despite a lot of training that goes into training the baby pilots, they still need to be reminded to carry out an anti-G straining manoeuvre, and their instructors need to keep an eye on them and check that they are, and coach them if they're not. So that's an ongoing issue that the flying training system needs to manage, and we've reminded them of that too. With that, hopefully an interesting tour of our little niche area here. Very interested in people's views, questions, thoughts on research quality, and I also have a chunk of references which will be on the slides if people would like to look further.
Thank you very